We're doing synovial fluids, which are not the same as serous fluids, not the same as CSF. So for that reason, they're covered slightly separately. They're still sterile and all that stuff, but the constituents of the fluid are slightly different, so we have to consider them separately. So the synovial fluid is taken from any of the joints in the body, and they are where most of your fluids are just an ultrafiltrate of the plasma. The synovial fluid will start as an ultrafiltrate of the plasma, but then as it's passed through the endothelial layer of the cavity of the synovial cavity, hyaluronic acid is the key thing that's going to be added to that ultrafiltrate, which is going to change the characteristics of the fluid completely. The cells of the lining cells of these cavities, the endothelial lining cells of the synovial cavity, are different from other cavity endothelial lining cells because they can synthesize your proteins that are normal to the cavity, but also they will be necessary for phagocytizing some debris that will build up inside a cavity like a joint cavity, and that debris has to be removed from the cavity. And if you think about a joint where you have bone on bone, over the years, wearing down, cartilage gets torn and broken and enters the cavity. So those endothelial lining cells are able to phagocytize. They have that feature, as well as synthesizing the proteins that are necessary to keep that joint fluid. Okay. The function of the fluid should seem fairly obvious, but the function of the fluid is to lubricate that joint and keep the joint nice and smooth as far as the movement goes. And then it's also the other function, just like every other fluid, is for transporting nutrients. And in the case of the joint, you're talking about transporting nutrients specifically to the cartilage layer. Okay, there's movement through the bone not very easily, so the cartilage needs to get its nutrients from the fluids, from the synovial fluid. The protein levels in synovial fluid, they're somewhat smaller, lower. They're quite lower than compared to plasma levels. They should be normally about a quarter of what you would find in the plasma. Okay, but the other constituents, electrolytes, glucose, uric acid, all of those things probably be about the same as what you find in the plasma. There are at the joint. Now in this cartoon here that we're showing you here, you can see it looks like actually a pretty large amount of fluid in this. In most joints, you have really less than 1 cc of fluid in there. So when you see swelling at a joint, that's a pretty good sign that you have some fluid buildup. And there are 5 different classifications or categories of any kind of fluid buildup that you might find in a joint. And we're not just talking about the large joints. Any joint could potentially see some infiltration. So the 5 categories that are there, you have group 1, which is non-inflammatory, so sort of an idiopathic increase in fluid. Group 2, which is inflammatory. 3, infectious. There's going to be some kind of organism noted there. Group 4, which is crystal associated, unique to joints, and group 5, hemorrhagic. Okay, so we're going to have to be able to determine in the lab, or we're going to give the information for the doctor to be able to determine which category applies to his patient when he sends us a fluid. The specimen itself is collected through the process of arthrocentesis, which is a thin needle is placed into the joint space and you extract the fluid. The fluid should be sterile. A sterile technique is used. We do want to receive the specimen not just because of the different characteristics of the synovial specimen. we don't just want to receive a sterile cup from this from this site. We do like to receive an anticoagulated specimen when we're talking about synovial fluid, if possible, and that would rely on having, collected enough of that. So when we're talking about an anticoagulated specimen, we have to remember that usually what we receive is an EDTA specimen, but we don't want to receive it in a powdered ETA tube. And that would be any kind of powdered anticoagulant, whether it's lithium, heparin, oxalate, or EDTA. And that's because by being powdered, they are necessarily crystallized, and so they could still maintain some crystal artifacts in the fluid, and we really want to avoid that at all times. So we must use the liquid version, which most hospitals have switched over. We don't usually keep the powdered versions on hand, although they do have a longer shelf life. So we have to make sure that we receive that we make sure that the OR only has those liquid versions in for their orthocentesis procedures. It's also important to remember that we don't only want a anticoagulated specimen. These EDTA, heparin, they have antimicrobial properties. So if you were to send just that, we wouldn't be able to use that specimen in microbiology, for example. Okay. We still do send the specimen first for blood counts, which is what we want that anticoagulated specimen for. We do chemistries, microbiology, and we do crystal counts, which is unique to synovial fluids. While it's not normal for it would be considered an abnormal finding to find clots, this specimen will be the first specimen to clot of all of them. It does have the highest percentage of clots that occur just overall. Okay, and those would usually be involved with inflammatory conditions, which would increase complement, and not just complement, but also coagulation factors, fibrinogen, all that stuff in the area. Of course, ideally, we're going to always ask for, larger amount of specimens. So a lot of times we ask for 5 mils because obviously we have a 5 mil EDTA tube, so that would be lovely. But it depends on how much the patient has in the site. It will depend on how much we get. Okay. We do want to set up our microbiology within 1 hour, and this is particularly important with a synovial fluid because one of the organisms that grows in a synovial fluid is GC, which, as you know from your microbiology class, is highly sensitive to temperature and loss of carbon dioxide. So you need to get it on a plate and in the incubator within an hour. If you do have a clot for chemistry, microbiology, anything like that, if you do have a clot for chemistry, you can easily spin that clot out and use the supernatant. That's not going to really affect many of your analytes that we will worry about in a chemistry specimen. In a microbiology specimen, if we do have a clot, we have a tendency to treat it then like a tissue and grind that clot up, and the situation there that we're thinking of is if there are any bacteria caught within that clot, we would want to release them by grinding them. For crystals, you have to look at those pretty quickly because they have a tendency to change. Obviously, as the specimen reaches room temperature, more crystals can precipitate, which would either increase, and some of them might actually dissolve over time, so then you might see a decrease. So you want to give an accurate amount, so we need to make sure that we analyze those as soon as possible. Since all since all fluid specimens are stat specimens, this is usually not a major problem. We can usually get to these specimens pretty quickly. Okay. This chart here, they're just giving you some basics. These are some basic findings that you might expect based on 4 different types of fluids that you could receive. Okay, the only one that's missing here is your crystal induced. Actually, they don't have the hemorrhagic here. Instead, they included a normal Okay. Um, so just to go through, we're going to switch to this chart, which includes all of the groups. You have your normal appearance, which is clear to straw colored, so that, but clear is the key thing, and a synovial fluid should not be cloudy. Okay, the color will be like a tannish yellow to a straw color. It does have a certain number of white cells that should be present. Um, and when we look at those, that we always do a differential on that. Your PMN should be less than 25%. Okay, shouldn't really have red cells in there, should not have crystals. And then blood glucose to synovial fluid ratio, you can see we use a ratio. You need a plasma glucose level to create that ratio that's collected concurrently, and that's 0 to 10. Okay, and culture, of course, should normally be negative. When you look at the different the different types of disease states, the different abnormal synovial fluids, we use the information that we get from, in particular, the white cell count, in order to differentiate the classification of the synovial fluid that we received. The first place you're going to start is with the appearance. And you're going to see that most of them are going to be in some way cloudy. 2, 3, 4, and even 5. There's going to be some kind of cloudiness involved because of the cell count. Okay. In the non-inflammatory group 1, it'll still be transparent, but you can see that it does tend to get a slightly more yellow color, which could be from an increase in protein, bilirubin, anything that might end up in that fluid. Okay, this is the group 1 is the non-specific. Why is that fluid in there? It's just not one of the other 4 reasons. Okay, so your white cell count stays relatively low in the group 1 with your PMN still staying below about a third. All the markers are, fairly close to normal, but there's just more fluid than should be there. Okay, when we get into groups 2, 3, 4, and hemorrhagic group 5, we end up with some significant changes. Your white counts can go incredibly high, and then your polymorphonuclear cells, or your SEGs, they tend to increase in significantly increase in percentage. Okay, a sign that there's some kind of inflammatory process going on. And then if you look at the glucose levels in these, those will change significantly as well. The most significant change will be if it's an infectious process. So you definitely need to know this chart, be able to interpret the numbers that you're given to be able to classify a specimen as either group 2, 3, whatever it is. Okay. There are some unique signs that we might look for in a specimen, in particular in the appearance. And one of those would be occasionally we see something called an ochronotic fluid, which is a fluid that has these dark speckled particles in it. It's called the ground pepper sign. So it really does look like you have ground pepper in the fluid. And what this is the patient has developed a buildup of homocysteine in the tissues, which includes the fluids, and that will come out as these little dark colored flake looking precipitate in the fluid. Okay. Something else that might be seen, remember that not all joints are natural. We do have patients who have prosthetic joints, and those prosthetic joints may develop swelling around them either right after the surgery or down the line. And it is not necessarily unusual for us to find fragments from the actual artificial joint, and those could be metal or plastic from the joint itself in those fluids. Your hospital will have procedures written as to how you report those, but obviously if you have little flakes coming off of the joint, it might be the joint itself might be coming to the end of its life. They don't last forever, so it depends on when the patient had it. had it placed in. These metal and plastic fragments can cause a discoloration of the fluid, including colors like blue and gray, and that would be usually only found in a patient who does have a prosthetic. And then one of the other things that we sometimes see, and usually it's in patients who have rheumatoid arthritis, they frequently have an increase in cholesterol in the fluids, and that will change the fluid to a dark yellow color. And that's because there's just increased, it's a fat, it's cholesterol in the fluid. So that would not be an unusual finding, but it's usually with those patients who have rheumatoid arthritis. Now, synovial fluids can be counted on the automated machine. That is possible. That'll be up to the procedures in your hospital. However, synovial fluids can be quite viscous, and so that viscosity does frequently lead us back to the hemocytometer. Okay, probably the most common fluid counted there will be your synovial fluid. Okay, the hemocytometer is still the gold standard, and if you do have a very viscous specimen, you got to get the hemocytometer out. You put that in your machine, and it clots in your machine. Everybody's going to be annoyed at you. Okay. Now, if you don't have, I mean, if you're taking out a regular, first time you're looking at this specimen and it looks clear, the clarity looks clear, you probably can go undiluted. The white counts are not that high that you would need to go that you would need to dilute it. The only time you have to worry about dilution is when you look at it the first time under the hemocytometer and you're like, oh my gosh, there's so many white cells. Then you start diluting it. Remember, you need to see them in a single layer in order for you to count them. Okay, so if you don't have a single layer, then you can't. You have to start over and dilute the specimen. Okay. One of the things that we do, if the hospital does allow you to use automation to do these counts, one of the things that is done, usually added to the procedure, is to add hyaluronidase, which will break down the hyaluronic acid in the specimen so that it kind of will help decrease the viscosity of the specimen. And frequently we also will also add toluene blue, and that would helps to also reduce the viscosity, and it'll prevent the formation of these any coagulate. And we don't want that in our machines. Okay. Now, the cells that you find in a synovial fluid, they're not going to look any different than any cells you find anywhere else. So these are just pictures of the cells. You already know what they look like. Probably the only one that you might not have seen before is the osteoclast, which is a specific cell to the synovial, to any joint. Okay, so these are things that you might see in that particular area. What you're looking at in all of these things, nothing unusual here. You see the sags here, lymphocytes. You see here's sags with intracellular gram-negative diplococci, and that's just because this is a gram stain. These are common to synovial fluid. These are synovial lining cells. They look a little bit different. Okay, kind of look like monocytes, but they actually are synovial lining cells, and you can see the little blebs that are on the outside of the cells here. These ones up here, what you're looking at are lymphocytes that are breaking down in these particular ones. You see how they're losing their nuclei? These are apoptotic cells. Okay. So nothing particularly unusual. In this case over here, Look at this particular cell here. We know that this is hemarthritis because you have a white cell. It's actually a macrophage that has engulfed red cells in it. Okay, so you know that there's a bleeding arthritis case here. Osteoarthritis, it's not much else going on in this except some white cells that are present, which remember those are supposed to be there at low levels. Inflammatory joint disease, look at all these sex. It's just an enormous amount of sex. Okay, so these are just a few things that you might see. Nothing different about the cells when you look at them in a synovial fluid than anywhere else. And remember, you're going to count the cells in a hemocytometer. You're going to do your diff in using the cytospin. Okay, same technique as for your serous fluid for your CSF fluid. What is different about synovial fluid is that frequently we have diseases where we have crystals that are associated with those. We have crystal-associated synovial fluid buildup. Okay, so when we have crystals, when we see crystals in the specimen, the gold standard for identifying them is to use polarized light, which, as you know, polarized light uses special wavelength compensators, which allow us to rotate light sources from one direction or the other from the specimen. So it is a much more highly technical procedure, and it's not something that an entry-level tech would necessarily need to know, but you need to know what it is and where you would send these specimens for identification. The types of crystals that we would see and the disorder that they're associated with for urate gout, or gout, which is a buildup of crystals in the joints. In particular, with gout, you're talking about the joint of the big toe. The crystal associated with that is monosodium urate, monohydrate, and then we have pseudo gout, where we see calcium pyrophosphate dehydrate, CPVD. Then we have apatite gout, which contains any of a number of calcium phosphates. You can see all the different calcium phosphates that are possibly found there. Then oxalate gout, which is associated mostly with renal dialysis patients. That's calcium oxalate, the different calcium oxalates. There are two versions of Wavelite or Wetalite versions, but it's the same calcium oxalate. One's monohydrate and one's dehydrate. And then finally, you could have cholesterol gout, which I mentioned a little bit before. Usually that's found in RA. Okay. What we're looking for when we take these specimens to the polarized light microscopy is we're looking for the presence of birefringence. It's a characteristic that some crystals have. Okay, so birefringence has to do with the color that appears when the wavelength parallel to it is present. So for example, with monosodium urate, these are needle-like crystals. That's what we see there, okay? And they're verified under polarized microscopy by demonstrating what's called negative birefringence. So this birefringence says that your crystal will appear yellow when the crystal is parallel to the red compensator, and blue when it's perpendicular to it. And I have pictures of these on the next slide. CPPD, however, demonstrates positive birefringence. Maybe it's easier if I go to the next slide, but let me just mention that calcium, the different hypoapatite and all those things, these usually are not birefringent, so they don't demonstrate birefringence. Neither is calcium oxalate. Do not. It's MSU and CPPD that demonstrate either positive or negative birefringence. If we look at these two pictures here, these three pictures here, you can see that these are where we're looking at polarized light microscopy. So what happens with polarized light microscopy is you have a refractive index that is built up when light that is traveling through the specimen travels at different speeds. Okay, and when they're traveling at different speeds, they're refracted in either a positive or negative manner. Okay, based on the direction or the whether it's parallel or perpendicular to a particular plane. What happens is well, there's a lot of physics involved, and you don't necessarily need to know what happens. You just have to know what positive or negative birefringence is. So in the case of MSU, this is demonstrating negative birefringence. Okay, now you would have to be the technician who knows which what your compensator is, which direction that's pointed at. But what you're seeing here is that you have, when you're looking at the red compensator filter is on, the crystals turn yellow when they're aligned, when they're parallel to the axis, the slow axis of the red compensator. But they're blue when they're perpendicular to that axis. Sorry, not axis. Okay, and that's called negative birefringence. If we move over here to CPPD, and this is again more difficult because you can't tell where the compensators are, but under polarized light microscopy, CPPD will be positively birefringent, and basically the exact opposite thing is happening. They'll be blue when they're parallel to what's called the slow axis, and yellow when perpendicular. Okay, so what you're seeing here, and one of the other big things that should point out to you, look at the difference in the shape. MSU is almost always these little needle-like shapes when they are in, when you find them in gout, and in CPPD you see there's multiple shapes. You have small rectangles, squares, some needles, needle-ish, needle-like specimens, but you have a lot more variety of shape. The oxalate crystals are going to look just the same. You're going to see those. And in some cases, you can see that they are intracellular. Here's intracellular CPPD. MSU can occur intracellular as well. And then we have our cholesterol, and you see the little notch taken out of the corner here, also found in the specimen. The chemical analysis for synovial fluids is not necessarily as extensive as on other fluids. Now we do still do a glucose level, although it's difficult to judge what would be abnormal. We frequently do find abnormals in glucose, and it doesn't necessarily point to infectious or non-infectious or anything like that. So the value of the glucose is less significant here in a synovial fluid than it would be in other fluids. Okay, we do have to, when we do glucose level, we do have to compare it to the serum levels, and usually what we find is that if it's less than 25 below the serum, it's probably non-inflammatory, because remember it's an ultrafiltrate. If it's more than 25 below, it could potentially be inflammatory. Greater than 40 below could be septic arthritis. So although it's not a hard and fast case. Okay, these are general rules. Protein is still a little bit more useful in the synovial fluid, and that's because, of course, you're measuring total protein levels. So if you have a significant increase greater than 3 grams per deciliter, you're looking at likely the signs of an inflammatory process going on. But an inflammatory process can apply to an inflammatory fluid, an infectious fluid, or hemorrhagic fluid. So again, while it's useful, it's not necessarily specific. Okay, and it really is just a demonstration that there's probably increased permeability at the endothelial level of the specimen. Okay. We do occasionally do uric acid levels. Usually, it would be done if there's no polarized light microscopy present. Okay, and so they do the uric acid and compare it to your serum level, and that helps the physician to identify gout. Okay, so the increased uric acid level would usually be associated with a patient who has gout. Okay. We do also do cholesterol levels. Again, our RA patients frequently have increased cholesterol levels in their specimens, and so identifying a total cholesterol level would frequently be, it could be useful. Okay. We also do identify lipid droplets in the fluid, we would do this with a Sudan stain or an oil red O stain. And this would usually be associated, where we usually find them in a fluid, in a synovial fluid, is actually within the neutrophils. So they've been engulfed by the neutrophils. While it is non-specific, we do find it in lots of different types of arthritis. And then from time to time, we also do lipids to try and rule out chylus effusions, which are very, very rare. They're not really the actual finding of chylus specimens, which you remember having those microchylons, having a hard time talking today, that do occur in serous fluids much more frequently, and less frequently in synovial fluids. But if that's what you want to rule out, definitely lipid level could help. As a general rule, these would only be ordered in those rare cases where you're really thinking that there's some kind of arthritis that you haven't been able to diagnose in any other way. Okay, and the picture that's given there is just showing you some fat droplets that have been found in synovial fluid. Now, synovial fluids we do frequently do testing for because joints and joint disease are associated with certain immunological diseases. So we do frequently get requests for immunologic assays on synovial fluids. And those diseases mostly include rheumatoid arthritis and SLE, which have a pretty significant impact on the joints, as well as a couple of other arthritic conditions. Okay, but the two most common are really SLE and rheumatoid arthritis. So that would mean that the serological tests that we would do on the fluid, not on the plasma, but on the fluid, would include rheumatoid factor, an anti-nuclear antibody, or a complement level. Okay, and the levels of these have been shown to be altered in certain diseases. And so with rheumatoid factor, which is a specific antibody that's found in patients who have rheumatoid arthritis, not necessarily in all patients, but in a large percentage of them. Well, about 60% of them will also maintain rheumatoid factor in the joints, in particular in their affected joints. This rheumatoid factor is an antibody which reacts with the Fc region of immunoglobulin G, and it's associated with a variety of versions. You have an IgA version, an IgG version, as well as an IgM version. The version that we're looking for in the synovial fluid for the most part is IgG. So we do find that we might have increased levels of those. Again, it's not perfectly specific, but about 60% of RA patients do have that factor in their synovial fluids. Then we can do antinuclear antibodies, which is a specific antibody that reacts with nuclear components. And while we do that test on plasma all the time, we also sometimes do it on synovial fluid. About 70% of patients who have SLE, which is systemic lupus erythematosus, will have an antinuclear antibody present in their joints. And about 20% of RA patients will have it, an ANA in their synovial fluid. Remember, this is specific to the synovial fluid. What's in their plasma is different, okay? It's different percentages. Probably the most useful thing to look at is the complement. So historically, we used to do a total complement level, which is called CH50, or it basically was total hemolytic complement. And that was actually we measured all the complement components together, and that was our historical measurement. Today we actually do individual components. So we measure the 3 key ones that we measure are C2, C3, and C4. And we can measure, we have machinery, that's on the automated instruments, and it can be measured through nephelometric methods, turbidimetric methods, or immunoturbidimetric methods. It depends on the instrument that you have. Now, normally, in a normal patient, so we'll presume all of us, we have complement levels in our joint fluids that are going to be about 10% of the total serum complement concentrations. So you would obviously need a serum level to compare the synovial fluid level with, okay? However, as you have increased inflammation of the joint, increased fluid buildup, you're going to see increased permeability at that joint, which would mean you would get increased levels of complement in that joint. So what happens as inflammation increases, we start to see complement concentrations reach 40 to 70% of the serum levels. This is a fairly wide range, but it's significantly different from 10%. But here's the difference. When a patient has RA or SLE, that complement is actually consumed by the inflammatory process. So what actually happens is that even though there's inflammation present, the complement levels are actually decreasing to that when you're comparing it to that 40 to 70%. So you have all kinds of other signifiers that there's inflammation, but your complement level does not reach that 40%. Usually it only reaches about 30% in the RA SLE situation, and that's so it's increased over normal, but not as high as normal inflammation. Just RA and SLE are actually consuming the complement through the process, okay? And so if you look at this chart here that we give you, we're telling you what the serum levels and the synovial levels are with the different disease states. So you have RA, you can be seropositive or seronegative, and that means you actually produce, you actually have an RA factor present, okay? And then there is also juvenile RA, but in those cases they're seronegative. If they're seropositive, they go into the seropositive classification. SLE, Reiter syndrome, ankylosing spondylitis, prosaic arthritis, septic arthritis, and crystal-induced arthritis. All of them would demonstrate in signs of inflammation because all of them have inflammation. But with RA and SLE, you see you usually have decreased, especially with the seropositive, and SLE, you have decreased complement, okay? Whereas with other cases, you can see complement is increased, okay? Septic arthritis complement is also going to be decreased because you're using that up in the whatever the organism is usually generating a response with the complement. And then finally, microbiologic exams. One of the things that we have to worry about with septic arthritis is that the joints can be destroyed very quickly by these organisms. So usually if we can prove that it's septic arthritis, this becomes an emergency situation for the patient because the damage that can occur to the joint, of course it can spread to the bone, cause osteoarthritis, that's always a problem, but the damage can be permanent. Okay, so the patient could lose the joint. Now, if we look at the causes for septic arthritis, they're largely classified as 2 types, either gonococcal or non-gonococcal. So what that means is it caused by GC or not? Everything else, okay? GC does favor the joints. It likes that space, so it does definitely move to the joints very easily. And so you do have to be able to screen the joints. It's not uncommon for labs to throw in a Thayer Martin or something like that on a synovial fluid. Staph aureus is still more commonly isolated, just sheer numbers, but that's true across the board with infections, okay? And you can see pretty much any organism, if it gets the chance to get in that joint, it will take advantage of it. We also do have, of course, those specimens that might include Lyme, which we don't grow in the laboratory. We would have to use serology testing in order to identify that, as well as Mycobacterium, which is, it's not crazy common, but a doctor might, he would have to order a separate culture because that's an AFB culture. And then we have fungi. Again, you'd have to order a fungus culture to make sure that you cover for all the fungus that could potentially live there. Okay. Now, one of the reasons the joints are susceptible is joints are much more vascular than other fluid spaces. And so there's really a very good chance of bacteria getting into the joints, in particular if the patient has some other systemic disorder. Okay, they're so vascular over other fluid spaces that you have an increased risk. Okay. There are other kinds of infections that we see based on the population. In kids, you can see beta strep group B. You can see Kingella. You can see strep pyogenes or Staph aureus as well. You can also see a Haemophilus influenza, although that has dropped off significantly since the vaccine was developed. If you are going to collect culture on this, and if you can get enough, you can use blood culture bottles. They're very good. But remember, some of these are very fastidious. So if you don't get it in the bottle very quickly, you know, Kingella, for example, which is not uncommon in a fluid, that's quite fastidious. GC is fastidious. So it needs to get in the bottle quickly. Now, Lyme arthritis is a particularly which is caused by Borrelia burgdorferi, which is the bacteria that's spread by the tick caused Ixodes scapularis or Ixodes pacificus, depending on where you live. These can be grown, but we don't grow them. Okay, it's actually highly technical to grow them. We don't grow them in the routine clinical lab. So for the most part, what we do is Lyme serum testing. Lyme serology testing on synovial fluids to see if the patient potentially has Lyme's arthritis. We should always start with serum testing, okay? Because if they do have Lyme's arthritis, they will have an antibody response in their plasma that will be there. So we do a screen, which is then confirmed by Western blot. So we do a screen, which is usually an ELISA or an IFA, and then we confirm that with a Western blot for the IgG and the IgM. If we get a fluid that the doctor suspects, the best way to test that is really with PCR. We can do culture, but PCR is best, okay? It's definitely not as sensitive to test the fluid as it is to test the tissue because the bacteria actually prefers the tissue, but we don't get as many biopsies of these sites. We usually get just the fluid, okay? But in either case, you would never do just the fluid testing. You have to do the serum testing because it is more sensitive. This fluid testing, even PCR, is definitely not as sensitive as the serology. And then this chart here from the CDC is just showing you the two-tiered testing that we have for Lyme's disease in the United States. And that is where we start with the screen, which is either an ELISA or an IFA. Just different methodology for the same thing. And then if that's negative, we can consider our patient negative and move on from there. However, if you get a positive or an equivocal test, you need to perform a Western blot. If you look here where it says signs and symptoms for greater than or less than 30 days, as a general rule, this part, while clinically that may seem like a good idea, we usually in the lab, we don't have any idea how long they've had the signs or symptoms. So we go from positive or equivalent directly to doing the Western blot, IgG and IgM. Okay, we don't know how long the patient has had that. We're not privy to that information. Okay, so a CDC frequently makes these nice charts for the doctor, but the doctor doesn't order the tests. We do. Once we get a positive on the screen, we reflex the Western blot automatically.